Hi and welcome back. Let's review heart failure. This is a very highly tested topic. Heart failure is a long-term condition where the heart muscles weaken and can't pump enough blood for the body's needs. This means that it's a chronic illness and things only get worse with time. Before we indulge into what heart failure is, I want us to quickly appreciate the role of this organ, the heart. When you understand how the heart functions, then the direction of blood flow, it becomes much easier to understand what happens when the chambers fail to do what they're supposed to do. Deoxygenated blood flows back into the heart from the lower body system via the inferior vena cava and from upper body via the superior vena cava. The very first chamber that collects this blood is the right atrium. The tricuspid valve opens up during early diastole of the ventricles, and then up to 75% of the blood in the atrium flows into the right ventricle via gravity, and then the rest will flow in, which is 25% during atrial kick or when the atrium contracts. And that usually happens towards the end of diastole, pushing the rest of the 25% of the blood into the ventricles. Tricuspid valve closes and we enter into the systole, where the ventricles start contracting. Pulmonary valve opens up and blood is ejected into the pulmonary artery to the right and left lungs for oxygenation. After the oxygenation of the blood from the right and left lung, the blood returns to the left side of the heart. The chambers that collect blood from the lungs is the left atrium. Again, during diastole, the mitral valve opens and allows up to 75% of oxygenated blood to flow freely into the left ventricle. Towards the end of diastole, the atrial kick pushes the rest of the 25% of the oxygenated blood into the left ventricle. It's now time for systole. As the left ventricle prepares to contract, the mitral valve closes and the aortic valve opens. Ventricles contract and oxygenated blood is pushed out into the aorta and distributed to all body parts. To the brain via the left and right carotids, to the upper limbs via the subclavian arteries, and to the thorax, abdomen, pelvis, and the lower limbs via the descending aorta. Now that we understand how the heart is supposed to function, let's now see what happens when we have heart failure. Heart failure develops through a progressive sequence. Initial injury or cause damages the heart, leading to impaired pumping, or the systolic function is impaired, or it could be a diastolic function, which is the filling function is impaired. This results in decreased cardiac output and poor tissue oxygenation to the organs. Then, when that happens and there's decreased perfusion, compensatory mechanisms kick in. They're activated and the body tries to maintain normal blood flow. But this can only happen temporarily, as with time it stops to work and these compensatory mechanisms become exhausted and harmful and causes heart remodeling, weakening of the heart muscles, stiffening and thickening of the muscles. And once the heart can no longer keep up, the patient will start having congestion, fluid overload, and organ dysfunction, the classic signs of complications of heart failure. So let's dive in. Heart failure can result from two major types of ventricular dysfunctions, systolic or a diastolic dysfunction. Systolic heart failure is usually related to a reduced ejection fraction. Let's find out why. Systolic heart failure is a pump or contraction problem because during the systolic is when we are talking about the ventricles contracting. So if it's a systolic dysfunction, it means there's a problem with the pumping, the contraction. The ventricles become dilated, overstretched, and thin, making them too weak to contract effectively. Because the squeeze is poor, the heart cannot eject enough blood during systole. And that's why we are talking about a reduced ejection fraction. Looking at the picture here, the two ventricles are very thin, the muscles are very thin, it's very dilated. So you can imagine blood is taking over the entire space, but the muscles are so weak they cannot eject much. So we have reduced ejection fraction. With reduced ejection fraction, which is the percentage of the volume within the ventricles that is pumped out, if there is a reduced ejection fraction, then we are looking to see a reduced stroke volume. If there is a reduced stroke volume, you are looking to see a decreased cardiac output, which means that blood backs up to to wherever it came from. So if it's the left ventricle that has a systolic dysfunction, blood is going to back up to the lungs. If it's the right ventricle that has systolic dysfunction, it's going to back up to the rest of the body. Let's look at the diastolic heart failure. And this one is associated with a preserved ejection fraction. Let's find out why. So, diastolic heart failure is a filling problem because during diastole, the ventricles are filling. Blood is flowing from the both atrium and filling out those ventricles. So, if there's a diastolic dysfunction, we are talking about a filling problem. The ventricles are not able to fill properly or fill up with enough blood to supply the body. The ventricles during diastolic dysfunction, the walls are very thick. They become stiff and hypertrophied, so they require more oxygen to be able to facilitate and keep them alive. Uh, Even with so much thickness and stiffness, there's less room for blood to fill during diastole. Look at that. There's more muscle and then less space for the blood to fill. The ventricles fill with less volume, but because the muscle is strong, they're thick and strong, initially it ejects a high percentage of that little blood that it received during diastole. How this will affect the heart function? There will be a normal or preserved ejection fraction because ejection fraction is a percentage, not a volume. A low actual stroke volume becomes a ventricle a low actual stroke volume because the ventricles fill with very little blood from the to begin with. So when it pumps out, yes, it will pump out almost the entire amount that's in the ventricles, but let's not forget that whatever was in the ventricle was less and is not adequate for the body's needs. So even with a preserved ejection fraction in diastolic dysfunction, we're also looking to see a decreased cardiac output, despite that having that preserved ejection fraction. And then so blood will back up into the rest of the body, or if it's a right side, and to the lungs if it's the left side. The most common cause of heart failure is ischemic heart disease, especially myocardial infarction. When heart muscles die, they cannot regenerate, leaving permanent scar tissue. Remember, and that's why we always reinforce this that heart is muscle and time is muscle. So rapid reperfusion is the goal here. Door to balloon time is 90 minutes. So the sooner we get the patient to the cath lab, the better. Other major causes of dysfunctions that can end up causing heart failure is uncontrolled hypertension, because with hypertension, remember, we are increasing the systemic vascular resistance, or the afterload. So, and that will be for the left side of the heart. If there is hypertension, we are going to see make it so hard for the left ventricle to pump out and push out blood into the rest of the body. And for the right side, if you're talking about increased systemic vascular resistance, we're talking about pulmonary hypertension within the lungs, because it pumps into the lungs. So if there's so much pressure in the lungs, then it makes it so hard for the right ventricle to pump out blood. Other dysfunctions are like valvular diseases, stenosis and regurgitation. I have a playlist talking about the valvular diseases and how it affects blood flow. Cardiomyopathies, these are sicknesses of the muscles of the heart. It could be dilated, hypertrophied, or restrictive. You have congenital heart disease, whereby someone is born with an issue, and this ends up causing heart failure. And then we also have toxins, where it could be alcohol, especially people who do alcoholic or a drug abuse. They end up messing up their heart muscles, or chemotherapy and radiotherapy. All these things can affect and cause cardiomyopathy. So let's talk about the compensations that kick in to support the body during this time when there's decreased cardiac output. So when cardiac output drops, the body activates several compensatory mechanisms to maintain blood flow. Activation of the sympathetic nervous system causes heart rate to increase and contractility of the muscles which were weak to increase, and arterial vasoconstriction to temporarily boost and push blood forward and boost cardiac output. But you can imagine already the heart muscle is weak. So when you vasoconstrict, increase that um, systemic vascular resistance or the afterload, then it makes it even harder for that left ventricle to function. And then when you increase the heart rate and increase its contractility, you're even giving it more workload. So the heart can only withstand so much pressure for some time, and then eventually it collapses. Another compensatory mechanism is the RAS system. RAS system is activated when there's hypoperfusion in the kidneys. So when the kidneys sense there's little blood flowing to the kidneys, it releases renin. Renin hormone runs into the blood system, and then it meets up with angiotensinogen, which is produced by the liver, and it converts angiotensinogen to angiotensin 1. Then we have the ACE enzyme, which is usually in the lungs, converts the angiotensinogen 1 to angiotensinogen 2, to angiotensin 2. Sorry, so let me back up. RAS system happens this way. Decreased blood flow to the kidneys. When the kidney sense decreased hypoperfusion, we are going to see that it releases renin. Renin goes into the blood, and it changes the angiotensinogen from the liver into angiotensin 1. Then ACE enzyme from the lungs will convert angiotensin 1 to angiotensin 2. And so angiotensin 2 is our savior. Angiotensin 2 will do three things. One, it will cause vasoconstriction by itself to increase blood pressure. It will also stimulate the aldosterone to be released from the adrenal glands, and aldosterone goes to the kidneys and helps to maintain a reabsorption of water and sodium. And then number three, it will send signals to the brain, especially to the posterior pituitary gland, for the ADH to be released. ADH goes to the kidneys and causes reabsorption of more water. So more water is being reabsorbed and maintained in the body, vasoconstriction happening. All these things work together to increase the blood pressure. Having said that, the third one that you're going to see is the Frank-Starling mechanism. That's whereby there's this, it's kind of like a law that when the muscles stretch, the more they stretch, the more they're going to snap back and create that pumping or a bigger contraction. But this is only up to a particular threshold, after which the heart muscles cannot stretch any longer, and so they start losing their contraction or their compliance. So it can only happen, like I said, over time, these mechanisms become harmful, leading to fluid overload, increased systemic vascular resistance, ventricular remodeling, and the signs and symptoms of heart failure become even more evident. So let's see the difference between right versus left-sided heart failure. This is a topic that is highly tested. Heart failure on either side can come from a pump or filling problem, but the key difference is where the blood backs up, and that determines the symptoms. Left-sided heart failure, we're talking about left side lungs being congested. When the left ventricle weakens, it cannot pump blood forward effectively. So remember, we are looking now on the left side, the left ventricle. It's weakened, it's tired, it's not able to pump enough cardiac output to the rest of the body to supply and perfuse every organ. So more will be backing up to the lungs. So blood backs up into the lungs, causing pulmonary congestion. And so with a left-sided heart failure, we are looking to see pulmonary or lung-related signs and symptoms. Shortness of breath, orthopnea, which is they cannot lie flat when they're sleeping because they will not breathe better. Paroxysmal nocturnal dyspnea. I always remember paroxysmal with pillow. So they need multiple number of pillows to prop their head up, or they end up sleeping on a reclining chair just to sleep in a sitting position for a better, they can tolerate that more and be able to sleep better in that position. So paroxysmal nocturnal dyspnea. Paroxysmal, I remember it with pillow. Then you will see other signs or symptoms related to the lungs, like coughing, wheezing, crackles on auscultation, and when it's severe. And at this time, you know you have to prioritize this patient because they're about to enter into a space where they have ARDS. acute respiratory distress syndrome. When they start to have pink, frothy, or bloody tinged sputum, this is a severe case because now the blood vessels are popping up and they're bleeding through that. There's so much fluid going in there. So this is a medical emergency. Low cardiac output with systemic with the left-sided heart failure can also affect different organs. You can imagine different organs which, when they're being hypoperfused, like the brain, the patient will have confusion, dizziness, restlessness, and syncope. Their peripherals, their hands and fingers, they'll be cool, weak pulses, poor cup refill. If hypoperfusion in the kidney can cause prerenal injury, the patient will be bluish, especially the extremities, from the poor oxygenation. Now, let's look at the right-sided heart failure. So, right-sided heart failure can result from either a pump problem, which is a systolic dysfunction, or a filling problem, which is a diastolic dysfunction. But really, what truly defines it is where the blood backs up, which is into the systemic circulation. So, with the left-sided heart failure, we're looking to see backup into the lungs, and so we are looking for lungs or pulmonary signs and symptoms. Right-sided heart failure, blood is backing up into the rest of the body, so we are looking to see signs and symptoms related to the systemic circulation or the rest of the body. So causes of right-sided heart failure, the most common cause is usually left-sided heart failure. So whereby the left-sided heart has failed, the left ventricle has failed, blood has backed up to the lungs, and now it's creating a high pressures or pulmonary hypertension. So it makes it harder for the left ventricle to pump out or into the lungs. So this is called cor pulmonale. It could be cor pulmonale. It's whereby because of issues in the lungs, it could be because of chronic lung diseases like COPD or a left-sided heart failure causing right-sided heart failure, cor pulmonale. We're also looking to see right ventricular ischemia. When you have a STEMI that affects the right side of the heart, which is the right ventricle, it can weaken those muscles and end up causing right-sided heart failure. And then, of course, chronic strain of the right ventricle can lead to right ventricle remodeling and weakening. So, left heart failure, pulmonary congestion; right heart failure, systemic congestion. Now we all know what has happened when the heart muscle was failed to work properly, and now we are looking to see that compensatory mechanisms are now weakening and getting tired and cannot help and support the heart anymore. So now we enter into complications. So when the compensatory mechanisms like the sympathetic nervous system, the RAS system, ADH, Frank Starling mechanism are exhausted, the heart can no longer maintain adequate output. This leads to progressive and severe complications like pulmonary edema, which impairs oxygenation and can cause respiratory distress, cardiogenic shock due to pump failing, the contraction ability has failed. That's called cardiogenic shock because there's inadequate cardiac output perfuse the organs. Renal failure from chronic hypoperfusion of the kidneys. The patient may have dysrhythmias and risk of sudden cardiac death because remember, if there's decreased cardiac output, there's also going to be decreased supply of blood to the coronary arteries. Hepatic congestion, liver dysfunction, when in the right-sided heart failure, things back up to the spleen, the liver, and this can damage the liver. And so you can imagine the liver is dying now and not functioning just because of the heart. Clotting risks such as DVT and pulmonary embolism due to venous stasis and congestion. Patients can progress from mild symptoms to severe fatigue even at rest, marking advanced decompensated heart failure. So when it's decompensated, that means that even during rest, this patient feels tired, dizzy, can even have a syncope episode while they're just sitting on a chair. Now let's get into the diagnostics for heart failure. For the labs, the main one that you will see or the first priority is looking for the BNP and ANP. Beta and atrial natriuretic peptides are the most common labs that they will be looking for, and they signify if they're elevated, then you are for sure this patient is having heart failure. BNP and ANP are released when cardiac muscle is overstretched, indicates volume overload and ventricular strain. We can also look for troponins to rule out STEMI as a cause for the heart failure or exacerbation of heart failure. We can do echocardiogram. This is a golden standard tool, diagnostic tool. So if you're looking for golden standard lab, BNP, ANP. If you're looking for the golden standard diagnostic tool, is echocardiogram. So even the choices you have echocardiogram and BNP, echocardiogram wins because it can diagnose and because it tells you a lot. The echo measures ejection fraction will tell you if it's a preserved or with reduced ejection fraction. It will also assess the walls of and the motion of the walls of the heart and the contractility. Is it weaker on right side? Is it stronger on the left side? So you're able to see that. It identifies valvular diseases if that's the cause. Maybe it's because of aortic stenosis or it's because of mitral regurgitation. It's able to look and see that. You can also do chest x-ray. It will show an enlarged cardiac silhouette or cardiomegaly. It can also reveal pulmonary edema or congestion, whereby you'll see the lungs look white and hazy. Bedside tests like EKG can detect signs of acute MI or ischemia or arrhythmias. Q-wave may indicate a prior or an old MI. So this patient has had an MI. Some people have silent myocardial infarction and they don't even know. So when they come in with exacerbated signs and symptoms of heart failure is when they realize, oh, they have a Q-wave. So they probably had a heart attack. They did not know, they did not feel the pain, and now we are here. Some providers measure cardiac output and intracardiac pressures like via catheterization that goes into the right side to measure the pressures in the different chambers of the heart and see if one chamber has more pressure, that means it's more fluid overloaded. Let's talk about interventions in heart failure. So heart failure has no cure. So treatment focuses on relieving symptoms, improving cardiac output, and preventing progression. During acute or decompensated heart failure, for pulmonary congestion or with symptoms like crackle, shortness of breath, you can of course give oxygen supplement via BiPAP, give diuretics to remove that excess fluid from the lungs, consider hemodialysis if kidney fails or the diuretics are not effective. We maintain strict ins and outs, measure how much this patient is taking in and how much they're peeing out. We also want to restrict their fluid intake because they're already fluid overloaded. You don't want them to be drinking gallons and gallons of water. To improve cardiac output, we can reduce the workload of the heart by either using vasodilators to decrease afterload and pulmonary pressures, or we can use positive inotropes to increase that contraction ability, dobutamine, digoxin to boost contraction. Chronic heart failure, we can also introduce lifestyle changes like tell them to reduce their sodium intake and as well as the fluid intake. Daily weights, that's the only way we know if the patient is doing well or worse. If they have to measure their weight first thing in the morning after voiding. They wake up, void, step up on the scale, and read their weight. If they have increased their weight by more than 2 pounds per day, then they need to call their doctor. Manage comorbidities like hypertension, diabetes, and coronary artery disease because these things worsen the heart failure symptoms. And for patients with ejection fraction that is low as less than 35%, they are very likely to get into a sudden cardiac death. And so they can benefit from implantable defibrillator, ICD. Also for end-stage heart failure where the heart is completely tired, it cannot pump much. They can benefit from left ventricular assistive device or heart transplant. Nursing considerations. Please tell your patient to monitor their vital signs at home, as well as like their blood pressure, their weights. But when they're in the hospital, of course, you want to monitor their vital signs, oxygenation, lung sounds, and signs of fluid overload. Track their daily weights and strict ins and outs. Assess for worsening edema like JVD, ascites, respiratory distress. Evaluate response to diuretics, vasodilators, and anatropes. Whenever we do an intervention, you want to go back and see and evaluate or reassess to see that your intervention was appropriate or not. Watch for electrolyte imbalances, especially potassium with diuretics or digoxin. Monitor for dysrhythmias and signs of decreased perfusion. Promote rest periods to reduce cardiac output, to reduce cardiac workload, not output. Promote rest periods to reduce cardiac workload. So you don't want them to cluster care or you don't want to cluster care with these patients, or you don't want to tell them that, oh, when you go home, do everything in the morning when you have more energy. No, because they are going to overwork their heart. So they need to spread out activities throughout the day, do a little bit of that, rest, then do a little bit of the next one and rest. Ensure medication adherence and monitor for side effects. Like if the patient comes in and tells you, oh, then you know they're on digoxin and they tell you they have nausea or they've been vomiting, then you know they're probably digoxin toxic level at this point, because hypokalemia is associated with high risk for digoxin toxicity. And the other signs and symptoms that you're looking to see if the patient has high digoxin toxicity risk, the nausea, vomiting, confusion, changes in their vision, all those things. What you need to teach your patients, teach them about daily weights, same time each time, every morning, a fasting every morning after voiding, and report rapid gains to the provider. Sodium restriction and fluid restriction, of course, we talked about that. Recognize early signs of and warning signs of heart failure getting worse, sudden weight gain, increased swelling, worsening shortness of breath. Taking medications exactly as ordered, never skip or double doses. Avoid NSAIDs. NSAIDs can worsen fluid retention because NSAIDs are really harsh on the kidneys. So if the kidneys are already hypoperfused and then now you're even making it less and less perfusion going into the kidneys by taking NSAIDs, you're making things worse. So because the more hypoperfused it is, the more renin the kidneys will produce and the more workload is going to put to the heart. Manage comorbidities like hypertension, diabetes, coronary artery disease. Encourage smoking cessation. Moderate activity as tolerated. I told you, do not cluster care with these patients. Spread it all out. With pharmacology, I want you to go into my pharmacology playlist. I covered this in depth, the pharmacology of heart failure. And leave in the comments what you think. To finish this video, I just want to put out a little bit of the things you are more likely to see in an exam. S3 and S4, extra heart sounds, which are common in heart failure. S3 is common with systolic heart failure, and S4 sound is common with diastolic heart failure. Pink floating sputum is a sign of pulmonary edema, and it's also a sign that the patient is worsening. When there's elevated BNP in the patient's lab associated with heart failure. Preserved, know the difference between reduced and preserved ejection fraction, and that preserved ejection fraction does not mean that it's better than the reduced ejection fraction. It only means that there's little being filled into the ventricles, and then most of that little amount of volume is pushed out, and so either way the patient will have decreased cardiac output. Right-sided heart failure is associated with systemic congestion. Left-sided heart failure is associated with pulmonary congestion. Daily weight is the most sensitive indicator of fluid status for the patient. ACE inhibitors, I want you to look at the side effects like cough that doesn't go away. This patient can tell their doctor and they can switch to ARBs. Also angioedema, high risk in ACE inhibitors and as well as ARBs. Digoxin toxicity is very likely when the patient is hypokalemic. Nitroglycerin is contraindicated with sildenafil or Viagra. And then for patients with very reduced ejection fraction may benefit from implanted cardioverter defibrillator, ICD, or heart transplant or left ventricular assistive device. That's it. I hope this review was helpful. If it was, please hit the like button, subscribe to my channel, and share the content with your classmates. I will be posting practice questions with answers and rationale to test your knowledge on this topic. Bye for now, and I'll see you on the next one.